There are some people who are not happy with this discussion about outcomes in patients who've had ongoing symptoms with regards to COVID infection and what happened after vaccination. The truth is that it is a difficult topic because many in the scientific community and possibly the medical community will be frowning at you are bringing the reputation of the profession into disrepute by raising these points. Now, what you have to realize is that this is based on real science. And this is a preprint paper that I'm going to be discussing factors associated with the deterioration of post COVID condition symptoms following a dose of SARS-CoV-2 vaccine. And one of the important principles you have to realize that is in play for the clinical community is the duty of candor, honesty, transparency. When something is wrong, you should say it. And so I would challenge anybody who thinks that we shouldn't talk about these things to say, actually, it is not in the interest of science or profession to put aside issues that can be uncomfortable. And what is uncomfortable here is the fact that it seems there was a proportion of people, not everyone, who should not have been mandated. And this is where the problem comes in. I have a feeling that if we hadn't been using COVID vaccine mandates, a lot of these issues from an ethical and the outcome point of view would have been different because people would have just chosen to do whatever they wanted to do. And if they had a negative outcome, it was their choice. Once you included mandates in that picture, you have better know what was happening. And this is now where the truth is that the science could not have been fully understood because we didn't have the time. Now, there are a few things we're going to be doing in this. I'm going to go through the paper, but I'll be explaining it in relation to my own research. And what I've got here is the paper we recently published at the end of December with Professor Turner and Professor Uhal, Central Role of Macrophages in Long COVID Pathophysiology. And uh, this is central to why I think these patterns happen. And if you understand this, it will help people to see why people would get sick when you stimulate the immune system further. If they're sick already, they get sicker in some people, not everybody. Now, what I want you to do is if you do have symptoms or if you know someone who has symptoms, you can join me in it. Just take me a long time to put, not a few weeks to put together, where this scoring, it's free to do, and it you can get the answers for your score at the end. It's about 26 questions, and it gives you an idea as to what your symptoms are like and what patterns they fit in. And in effect, at the end of the presentation, I'm just going to show you what people will get. It is something like this, an example phenotype score. It breaks it down into 4 different categories, including neurology, gut, vascular, epipharyngeal, and vagal. And it's not a diagnosis, but it helps when you think about it clinically. Where is their problem and what should be addressed and why is it that they're struggling? And this is the case for many people. They just don't know what's wrong with them. They don't know why they're sick. Nobody's finding answers. It is difficult because the research is so poorly understood. But when we come back to this paper now, you have to understand the implications of what it's saying. So let's just go through a few points with regards to this paper. The first thing you must know is that it's a preprint. That means it hasn't yet gone through peer review. So it could mean that when the reviewers look at the paper, they say, we think this is wrong, this needs to be fixed. And so some of the things in the paper could get affected. However, the data which is what I'm interested in, is very important, and it gives some critical signals. I wouldn't be surprised if this kind of paper doesn't get published because it has such a significant impact on that narrative that you have heard. The first thing that you have to realize, so this is a Canadian study, so all of the affiliations were in Canada, and they looked at multiple areas of Canada looking at patterns. And they were investigating factors associated with deterioration of post-COVID condition, long COVID, symptoms in patients who received a COVID vaccine more than 90 days after infection. This is important because in order to have post-COVID, long COVID patterns, you need to have it for at least beyond 90 days for it to fit within the WHO criteria. And so when they did that and they looked across 33 emergency departments in Canada, they found out of the cohort, they eventually found 476 people who had what the World Health Organization would have been considered post-COVID or long COVID, and then they followed them up. Okay, now this is important because as the authors highlight, and this is where it gets really complicated, that some people say, well, this is not the kind of research that we need to do. Here is what the authors said. Here is why they did it. They pointed out that only a few studies have been conducted on the impact of vaccination administered after a SARS-CoV-2 infection on people who already had immune dysregulation. So they knew that additional research is needed to understand whether stimulation of the immune system through vaccination has an impact on these symptoms in people who fit the definition. The principle is very simple, is that it's not just the viral infection that causes problems in COVID. It is the spike protein. Now, I mean, if people don't get that, I can't, there's nowhere to start, because if they just think it was a viral infection that did this, it doesn't make sense. But when you understand that the viral infection in the context of spike protein exposure to the immune system drives these unusual patterns, then it starts to make sense. Because, and to be frank with you, I mean, I had said this before, and it probably got me into trouble, because I was saying, listen, when you're bringing the vaccine in place, because I was looking at autoimmune responses related to the spike protein, I'm saying target your high risk, people who haven't been exposed and have high comorbidities, diabetes, hypertension, obesity, that's where you go. And that was the plan until, I don't know, until maybe they saw that this could make a lot of money, or the politics. I have no idea what made them suddenly change their mind. It happened first in the US and the whole world just followed. It was just crazy. They in effect, this is my rant now, in effect, the first world countries chose to force vaccinate their population rather than giving vaccines to third world countries who had high-risk patients. I mean, it was unbelievable. And I thought, they clearly have no understanding of the science, because if you did, you would know spike protein is your problem. Why would you broadly give it to the population? Focus on your high risk who hadn't been infected. So this is the second part of my rant. Imagine, and one of the senators in the US asked this question, and he put it in front of the CDC, and they had no answer. He said he had recently been in hospital with moderate COVID. He comes out and he's being told to get vaccinated. And he said, well, have you done any testing to see if it actually is beneficial for me? I've already had an immune dysregulation cytokine storm on exposure to the virus with the spike protein. Are you sure that giving me more immune stimulation is actually going to be of benefit? They didn't answer his email, and it went silent. They didn't know, because nobody knew. I mean, how could you know? And so they then, I think the problem was that the minute you started to break down categories, you would struggle to convince the whole population to take it. Suddenly, everybody would say they had infection and they wouldn't want it, and so it was a public health dilemma rather than a scientific issue. And this is why I think it was done. But here is the principle, and now I'm going to be showing you what my research was looking at. And so if you're interested, as I said, look in the description below, do the test, keep the results. Even if you don't share your email, keep the result, because you can do it again and see if things have changed over time. Share it with a friend, ask them to do it, because I've designed it in such a way that even if people don't have a symptom, they will better understand the kind of symptoms people are struggling with. So it's educational even for that reason, if you just want to go through it. But our paper focused on macrophages right in the middle here. Now, these macrophages, we essentially said once spike protein got in them, they become overactive. They can drive clotting, they can drive autoantibodies, they can cause mast cell interactions, they can suppress the regulatory cells, which then leads to brain-related symptoms. And what we're looking at is all of the patterns around this activated macrophage. And these tend to get more activated if you have gut-related issues. That's the general principle. And so the point is that in people who already had this activated macrophage, probably with spike protein from infection stuck in them, why would you give them more spike protein? That is essentially the question that the research was trying to answer as well. Well, what were the outcomes? That's the kind of question that we should have been asking. And what they found was that essentially 30%, 28.8% to be exact, worsened after they were vaccinated. That's a big number. And what you can see is that when you look at it here, what you can see, these are the numbers in gray. It's the ones who deteriorated. In blue, they had no deterioration, looking at the total numbers. And you can see across the board how many patterns post-exertional malaise tended to have the most: shortness of breath, memory issues, concentration, and all of these things deteriorated in up to 30% of the people who already had symptoms. For balance, it's important to say 10 of the 476 had some improvement. And even that is interesting because it fits with some people who had post-COVID patterns or long COVID patterns who improved after vaccination. My feeling is that what happened in those cases was that they got IgG4 antibodies, which then told the immune system to stand down, and so therefore the symptoms improved. That's my personal opinion, not necessarily the fact, but that makes sense. The others then found that they had worsening symptoms. And when you looked at this breakdown, the people, well, on the left indicates the factors that are not really associated with worsening symptoms. On the right, the factors that are. And the symptom that stood out the most is cough here, taste, and if they were bringing up sputum. And what they found was the vaccine that had the highest was Moderna. And I suspect they used Pfizer and AstraZeneca as a reference. So it's not that they didn't. It's just that the strongest response was with Moderna. And you have to remember that Moderna has the highest dose of spike protein in it. And so it has a stronger immune response. And so therefore it is not surprising that they would have worse outcomes in that case. You will hear from other people, they will say that there is a lot of research out there showing that COVID vaccines protect against long COVID. And when you look at, this is one example of a systematic review. And I think what you have to look at as I pull down, looking at all the studies that it looked at, every single study showed benefit or protection with regards to being vaccinated. I mean, it's no wonder then. So the scientific community says, well, listen, there's only benefit here. Why would we worry? Here's the problem. Now, this is where you have to understand clinical points. If, for instance, you must have heard of atrial fibrillation, an irregular heartbeat that increases your risk of having a stroke. And so we manage that. We reduce the risk by using blood thinners to thin the blood down and reduce the risk of you making a clot in the heart and throwing it to the brain. Now, what they were doing with this kind of study is that, and this is how you would get lots of benefit, is if you then said, similarly, we're going to give everybody, say over the age of 60, anticoagulation and see if it reduces the risk of stroke. And we would find it. It would be great. You would think, wow, that's great. Everybody gets anticoagulation. We reduce the risk of stroke. But if you are not looking for bleeding problems, if they have an upper GI bleed, or if they have a brain bleed, or if they have any other complications related with anticoagulation, you would be left with the impression that it only brings benefit. And this is the problem, is that the studies were not designed to identify the people who had negative outcomes. They were just looking for positive outcomes because it would reduce the risk of long COVID because it reduced the risk of people getting into hospital with severe COVID-19. But that's the high risk, not necessarily everybody, because the risk profile across the demographics of the population varies. To further immune stimulation. And this is the point. People think that people who have long-term symptoms ended up with severe disease. No, very often they had mild infection and they had a hyper immune response. And so if you then give that person who already has a hyperimmune response further stimulation, you will worsen their hyperimmune response. And this is where, when you don't understand the mechanisms around what happens with severe COVID, with persistent long COVID, you will then lump them all together. Somebody who had severe COVID and was on intensive care with heart and lung damage, who feels short of breath, is not the same as the person who had mild COVID and feels short of breath. It is literally a completely different pathophysiology. And so if you don't understand those things and you treat everybody the same, one, that is not good medicine. That is all that we do in medicine. We risk stratify. We try and identify who will benefit the most, who is going to be at risk. You don't put everybody on aspirin. It has benefits, but some people, if they have a history of peptic ulcer disease, will bleed. That's medicine. You have to think about who is in front of you and what problems they have. And so this is why they had this situation where now you have people who had ongoing symptoms. They knew they had COVID. They probably should have been very cautiously vaccinated. Now, at the time, they wouldn't know that cough was an important risk factor for worsening of the symptoms, but you should have researched it. Don't tell people that there is no issue when you haven't done the research. Be open, be honest, and say, listen, well, we don't know, but we think that this could be beneficial. But then when the person asks you, but you know what, I just had COVID, why are you vaccinating me again? And they go, well, we think that it will make your immune system stronger. I'm telling you, with immunity, there is no such thing as super immunity. You either have normal immunity, poor immunity, or autoimmunity. There is no super immunity. And so therefore, if someone has immunity, immunity is about precision, doing only what you need to do to get rid of the pathogen. Anything beyond that does damage. It's like a scar, somebody who has keloid skin. You need the skin to just heal perfectly so that there is a nice, neat scar. If that skin continues to produce too much skin cells, you can get a lump over the scar, and that's a keloid. Everything in the body is about precision, doing only what is needed at the right time. If that's not understood by now, I mean, and this is the point, is that there needs to be an acknowledgement for the people who have been harmed. Don't pretend that this was no big deal. Collateral damage, for the benefit, for the greater good. That does not help the person. What you should say is that we have learned better now. We are sorry, and we will do our best to remediate the situation. That's good medicine. That's good science. That's not what has been happening. And you know what? There's a lot more to come, because too many people have just been ignoring what's happening. The research should have been done. This is why I said, if you think this is bad with regards to what I'm saying about people with post-COVID conditions, 30% worsening, wait until the autopsy reports come out. When those finally come, because I know what I'm expecting to see, and there will be no hiding, because they should have been done. It's not acceptable that the science is not done. It's not acceptable that people early in the pandemic, in 2021, were being taken off Facebook for misinformation, for saying that they are having symptoms. I mean, terrible. Science should have immediately picked that up and done something about it. So as a final thought, for those people who want to understand more about the patterns of symptoms, please do that scoring. It's free, and at least you will learn the generalities of the symptoms. It's not perfect, but it's my interpretation as to how to risk stratify different characteristics and phenotypes around long-term symptoms. So we will continue to bring you more information. We'll continue to bring you the science. We'll continue to challenge the narrative, because that's what science should do. Have a good evening.
A hero, an immune adventure. Humming Heroes, your lyrical guide to the body's defenders. Now on Amazon. Check the links below.